First session. Good afternoon, everyone. This is Dr. Deborup from Medical College, Kolkata, and today I shall be discussing on monoclonal antibody. From the name itself, this monoclonal antibody, it is originating from a single clone of cells composed of IgGs. But the interesting fact is that whenever we tell about monoclonal antibodies, we always associate us with some tongue twisters, and there will be tongue twisters definitely. But I shall be trying to focus on systemic uses part, as various immunological aspects has been discussed already, and I have to cut short the session because of time constraint. First of all, let us begin with some facts about the history. The golden era of monoclonal antibodies started with Nobel Prize in Physiology and Medicine in 1984 by these three pioneer scientists, Niels John, George Scholar, and Cesar Milstein. They invented the principle of hybridoma technique used for monoclonal antibody production. This is in brief about the hybridoma technique, which is formed from the murine cells, that is mouse cells collected from the spleen of the mouse, immunized with antigens. Followingly, there is production of production of hybridoma cells with the help of myeloma cells, and subsequently, after subsequent screening, we produce hybridoma cells capable of production of monoclonal antibodies. But the initiation was not fair enough. There were fallacies, so there was inadequate efficacy due to immunogenicity of the murine antigen. So these modifications have come across. First of all, I have to tell about humanized and chimerized monoclonal antibodies. The humanized form resembles more than 90% of the human IgG nature, and the chimerized form resembles more than 65%. There are advancements regarding Fab fragments and single chain antibodies, and there are also some modification regarding bifunctional bispecific antibodies, as well as now conjugated forms have been made with drugs and toxin. I shall be discussing each and every part with examples when I proceed to the systemic uses of these antibodies. First of all, let us see about basic nomenclature from this example, that is palivizumab. First of all, this pali part is prefix. Secondly, the substem A, that is target, it is VI. VI indicates viral antigen. So this is targeted to viral proteins. Next, substem B is source, that is ZU. ZU means it is humanized form, and that is MAB, which is universal for each and every monoclonal antibody. Next, let us shift to the systemic ones. Here I shall be trying to give examples of those various modifications. In the field of multiple sclerosis, in relapsing remitting type, there are multiple monoclonal antibodies like Elotuzumab, Natalizumab, Ocrelizumab, and Ofatumumab. These are very much effective in preventing the immunogenic pathogenesis of multiple sclerosis. To be noted here, Natalizumab causes one significant side effect, that is progressive multifocal encephalopathy caused by JC virus. Another thing to be told here, Ocrelizumab, the beta cell depleter, can be also used in case of primary progressive multiple sclerosis. Next, moving on to migraine, there are some recent advancements regarding the pathogenesis of migraine, and it mentions CGRPs. CGRP antagonists like Eftinezumab, Erenumab, Galcanezumab all have been approved. Now, the last but not the least, in Alzheimer's disease, Aducanumab. This year only, this has been approved by FDA. This is one monoclonal antibody acting against the amyloid beta. So let us take a look at this picture taken from the Nature journal, showing the PET CT scan. After applying this Aducanumab, there is significant reduction of the SUV on the right hand in case of a Alzheimer's disease. Next, let us move on to the hematology and hematological oncologies. As we all know, rituximab, being a beta cell depleter, has been used in case of NHL, Bardet lymphoma, ITP, and AIHL. Next, brentuximab. Brentuximab is an conjugated monoclonal antibody which is conjugated with another anti-cancer agent, that is MMA, used in cases of ALK negative anaplastic large cell lymphoma. Next, I would move on to Caplacizumab, because this is one very important drug that has been approved in case of TTP. We have to just look at the mechanism of action of this Caplacizumab. Caplacizumab basically binds to the undegraded von Willebrand factor, and it prevents the aggregation of platelet with the VWF. Thus, it inhibits the microthromboid formation in case of TTP. Next, let us move on to multiple myeloma. Daratumumab and Elotuzumab, these two monoclonal antibodies, are thoroughly used in case of multiple myeloma. Basically, these drugs bind to some surface receptors like SLAM7 and CD38, and it activates the NK cells to destroy the multiple myeloma cells by ADCC. Next, Alemtuzumab is also used in cases of myelodysplastic syndrome. Last but not the least, in hematology, Amicizumab, a new drug which is a bispecific antibody which bridges the factor 9 and factor 10 interaction in the coagulation cascade, and it replaces the factor 8 basically. Next, let us move on to oncological aspects. I will brief here shortly. Trastuzumab is very well used in solid organ, breast carcinoma, HER2 positive tumors. Ranibizumab, bevacizumab also have been used in colon cancer and glioblastoma. Nivolumab and pembrolizumab, these are anti-PD-1 agents. Particularly, these are cell checkpoint inhibitors used in metastatic solid organ carcinomas. There are some recent advancements regarding radioimmunotherapy, where these radioisotope tagged antibodies are targeted towards lymphoma cells. Next, let us move on to respiratory system in bronchial asthma, which is specifically a case of Th2 response mediated pathogenesis, where omalizumab, which is IgE antibody, anti-IgE antibody mAb, as well as mepolizumab, reslizumab, benralizumab, dupilumab, all have been targeted towards this Th2 response pathway and has been approved in cases of severe to refractory asthma management, which also approved by the GINA in their latest guidelines. Next, in the cardiovascular system, we have lipid lowering agents like PCSK9 inhibitors being evolocumab and alirocumab, Amicizumab being and GP2B3 receptor inhibitor used in cases of unstable angina and coronary interventions. Next, let us come to the most important part, that is rheumatology. It is very well known that many antibodies are there in case of rheumatoid arthritis, being TNF alpha inhibitors like infliximab, adalimumab, golimumab, IL-6 inhibitors like tocilizumab, IL-1 receptor antagonists like anakinra, rilonacept. But in the field of SLE, there are some modern advancement. Belimumab and rituximab has been approved by Euler as well in cases of management of refractory lupus nephritis, and anifrolumab from the trial outcomes of TULIP-1 and TULIP-2 study have been well efficacious against non-renal lupus patients as well. Next, let us move on to some spondyloarthropathy cases and psoriatic arthropathy, which are basically IL-17 and IL-23 axis mediated disorders. Apart from infliximab, secukinumab being an IL-17 inhibitor and IL-12 inhibitor, ustekinumab has been used in case of spondyloarthropathy and psoriatic arthropathy also. We can use certain mAbs in case of rituximab and tocilizumab as well. Let us move on to gastrointestinal system. In cases of pseudomembranous enterocolitis, a toxin-bound monoclonal antibody, that is bezlotoxumab, which binds to the Clostridium difficile toxin B, has been approved for use in case of recurrent CDI. As we all know, it is the anti-TNFs are very well approved in cases of IBDs. The mAbs doesn't spare a system. So in endocrine, there are denosumab and romosozumab in endocrinal system. So we cannot ignore COVID-19 in the pandemic. So we have the antibodies like casirivimab and intevimab, which are active against COVID-19 viral antigens. They are used in case of mild to moderate disorder. And recently on November 18, just NEGM has published a new drug named sotrovimab, which has been also showing good signs of activity, reducing the hospitalization in cases of mild to moderate COVID. And I have already at start explained about respiratory syncytial virus and palivizumab. Lastly, a brief note on adverse effects. There are some adverse effects like infusion reactions, which can be prevented by slow infusion, giving pre-medications. As my previous speaker told about cytokine release syndrome, this can be also associated in cases of monoclonal antibodies, particularly used against solid organ tumors or hematological malignancies. There can be resistance also. It can be mediated by the tumor itself, or it can be mediated by the immunogenic nature of the monoclonal antibody. Lastly, but the most important part, we have to prevent the patients from infection flare. We have to screen for salient infections. First of all, we have to do serology, and we have to rule out latent tuberculosis. Then we can administer all these biological therapies.
Your time. Okay.
Thank you very
So
much.
I think there cannot be any question.